Thanks, everybody. It is a pleasure to be here again at this meeting. I see here that I have Leticia, my daughter, and also Victor Morel came back to town just to see this. And what I will kind of summarize the concept involved with the cone after Stern in general, and at the end, I'll talk specifically about the cone after Stern after Fontan. So the overall neonatal operative mortality used to be 27.4%, according to the STS database. And also, we have high mortality in patients who were operated in the first year of life. And besides that, the perinatal mortality in newborn with ABC anomaly is about 50% in a study in multiple centers done a few years ago. And the operation that has improved as a result is the operation developed by Starnes in 1991. Everybody explained that operation already, but basically they exclude the right ventricle by placing a patch in the supravalvular position and also preserving the coronary sinus and draining in the right atrial side of the patch. So we'll provide some flow to the RV, but the filling pressure will be very low. And I appreciate very much the presentation of Dr. Jacqueline Kreutzer, because it's impossible to see how the ventricle is inside if you don't have filling pressure. So when she injected the right ventricle, we saw that you could see the heart beating, because then you have the dye create some volume inside the ventricle. But why to do the Stern procedure, not just do a shunt? Here you see the reason, because when you exclude the RV, it gets smaller. So it decompresses the left ventricle. Then it can be filled completely and can manage much better the flow to the lungs by a shunt and to the body. So the physiology of the left ventricle is much improved, and that's why the result is better than doing only a shunt. So the other reason is that the Stern procedure can be reproducible. Not all surgeons have experience doing a cone, and then he has to do a cone in a newborn or another type of repair in a newborn, repair the trachea valve is difficult, while a Stern procedure is much more reproducible. But after the Stern, the right ventricle undergoes progressive involution, and then they used to commit it to the patient to univentricular heart by doing the Glenn and doing the Fontan procedure. But in 2019, we start thinking about that when we read a paper where they present that kind of involution of the right ventricle. And then I said, well, at some point the ventricle must be okay to be rescued and repair the trachea valve. And then our group discussed that possibility and did in a case that actually Victor Morel had done this Stern procedure. And here's the case, which has been discussed already. it is important that during the operation he opened the pulmonary valve, and that gave some volume to the right ventricle. So the difference is when you don't need, if you have a gland, for example, pulmonary atresia, you have a gland. So you need just some more additional blood flow to the lung. So you don't need the right ventricle to be very good to do that. But if you open, during the gland, if you open the pulmonary valve to some extent, just a little bit, then you can have more filling pressure to the right ventricle. Then initially, you have more flow, more additional flow to the lungs, and as compared to no opening. And for that reason, those patients evolve with a higher O2 saturation from the beginning. The other thing that is essential, and you do the cone after start, is to leave an opening in the patch that closes the ESD, because otherwise the RV will be, cannot manage all the volume of blood, and the patient will have low cardiac output. This has been discussed. So this is a situation, this is a case that Luciana operated, similar to Victor. She opened the pulmonary valve, and then you can see in the right that the right ventricle got bigger. So the O2 saturation, this patient, was over 90% after she did the cone repair. So essentially, if you do something to the pulmonary valve, even pulmonary atresia, and then you have more possibility of developing the right ventricle to some extent. The other thing that I want to mention, if you have a competent pulmonary valve, then you don't have to ligate the pulmonary valve. You have just to do the Stern procedure, because that too will facilitate the next operation. And we saw an example when Dr. Kreutzer did the heart catheterization on one of those patients. You have also, in theory, a better right ventricle. Well, this is an example. I'm not going to show that because people already discussed it. This also has been discussed. But you see, a heart in this size, it would be very difficult to be addressed surgically, if not nowadays with the Stern procedure and with the help of ECMO. And this is a case that Victor did. I'm happy that I was away, not in town, and he did this case very nicely, and the patient survived. And we have this long-term result of another patient where you can see that the right ventricle that was very small now has a normal size. This is a movie on the cone repair after the Stern, but I will skip it because Luciano already saw a nice movie on the cone after Stern, and then it's the same thing, the same operation. So I'm going to show just a few details. First, preoperatively, we saw this MRI in the left where you have a small right ventricle. See, the patient was almost 8 years old. And in this case, we did the, I'm sorry. Well, what encouraged you? How can you return this? Ah, here, I can see you. Now, next. So what I want to show here is that you can see in this picture the pulmonary valve there. So the surgeon actually, he made the stenosis above the pulmonary valve, and in the cath lab we could see it very nicely. So we knew that we have the pulmonary, a three-leaflet pulmonary valve, and that was encouraging, to do this operation, which was done for the first time. And the other reason is that the cardiac conduit was very small, was 13 millimeters for the girl, and she became very big. So she was having limitation, she could not exercise the limitation. And here you can see in the right the post-operative MRI showing that the right ventricle has grown. So here I want just to show the picture of the patch, the Starn patch, with the hole, with the fenestration. And this was removed carefully. This was not a PTFE patch, so very hard to remove. Here in the right, I'm reconstructing the tricas valve. So the tissue is very reasonable. And you see here fibrous tissues at the annulus from where we removed the patch. So it's very easy to suture the valve, to reattach the valve after you construct the cone. So the other part of the operation was to reconnect the inferior vena cava to the right atrium. In this case, it was possible to remove all the conduit. You can leave it too if you need, but it was possible, so we removed it. And then we did the closure, the ASD closure. And you see that there's an instrument across the fenestration. The fenestration was about 5 millimeters in this patient. That is a little bigger. So this I'm closing the ASD. And here in the middle is the pulmonary valve. So you see that were some stitches near the commissure insertion here in the wall, the posterior wall, and then the surgeon simply closed it. But there was a little hole of about 2 or 3 millimeters. So we opened toward the Valsalva sinus on both sides and removed some of those scar tissues in the back of the pulmonary artery. And then we enlarged that part, the left Valsalva sinus with the patient's own pericardium, and then we put a big patch enlarging this corner, this Valsalva sinus with the left Valsalva sinus and the whole pulmonary artery. Here just to show that we have 18 patients, 19 now, additional, a new one. And most of those patients have a good valve function and good ventricular function. So if you look, the only one patient had dysfunction of the right ventricle, but that patient had the cone repair at 2 years of age, and then the surgeon put a gland, didn't work, the ventricle was too big, then he put a Starn patch. So this is the only patient who has severe dysfunction. But he's improving, and clinically he's doing well. And in that case, we cannot see well the right coronary part of the right coronary artery. So I believe it has something to do with lesion on that artery. And the other thing is the valve, tricas valve, usually work very well. Now we have one case that's not doing well regarding that, but this was a patient who had pulmonary atresia, And so she acquired pulmonary regurgitation. She was too small, so we put a valve, a monocost valve, which is not working. So she has to be readdressed to replace the pulmonary valve, and we repair the tricast valve. Here's the data regarding the patient that we did the cone after Starn and after Fontan. It has been shown already, but I want to stress that the right ventricle had only 25 ml of end-diastolic volume per square meter, and this doubled in 6 months. So this is very significant. And the right ventricle ejection fraction was 10%. But obviously, this does not represent the real function because you don't have volume inside the ventricle, enough volume. So the filling pressure is very low. And then it is still a little depressed. It's 36% after 6 months. But I believe it will be much better in the future. So I would resume all the concept about Abs anomaly, that to improve the result, we have to do treatment since the beginning, since the fetal life, since diagnosed as necessary, especially if you have a circular shunt. The right ventricle rehabilitation with the cone repair after the Starn procedure provides excellent clinical outcomes, encouraging the use of the Starn procedure in critically ill Abs anomaly neonate, since in the future you can rescue the right ventricle. And preserving the pulmonary and tricast valves during the neonatal intervention is essential to facilitate the subsequent step in this staged approach. Thank you very much. I think there's some questions.
Yeah, Dr. De Silva, while I have you on the stage, there were some questions about how you preserve the pulmonary valve function where you're doing the cone post-Starns. So what's your approach to the pulmonary valve?
Well, if you have like circular shunt, then the valve is there. When you release the obstruction, you can, you don't have to do much. Normally, you can do some conchoratomy, some little repair. There's not, or nothing. In the case I presented here too, I was like a supravalvular obstruction. In that case, I enlarged like you do in supravalvular obstruction in aortic valves, that you make incision toward the valsalva sinus, and then the valve open up, and then you have the repair. And the other thing is the valve doesn't have to be too big, since the ventricle is small. Now, if you have cases of true pulmonary atresia, anatomic pulmonary atresia, then you don't have tissue. I mean, what I call like a muscular pulmonary atresia, that you don't have any tricast pulmonary valve tissues. In that case, you have to put a conduit. If the patient is too small, you may use a monocusp, but ideally you should put a conduit like Luciana showed here. Then, if you have a valve that is a membranous type of pulmonary atresia, then we have some techniques that you can do. You can do conchoratomy, you can enlarge in the leaflet, and sometimes you can get a good result by doing that. In our first case, we did that, and because once you open the valve, that area grows. And then we have developed some techniques that I have to publish which can help in repairing those valves. So basically, that's what we do to the valve. If we cannot repair, we put a conduit.
Thank you so much. That was excellent.
Welcome. Is there anybody that's going to come? I'm the last one.
I got it from you. Thank you so much. All right. Well, thank you so much, Dr. De Silva. I think you all agree that our surgeons and our fellows had a wonderful presentation. So let's give them another round of applause. And just like some take-home messages of this surgical session is that, as we saw in these multiple cases, that the cone operation can be performed successfully in patients with severely displaced tricuspid valve, after the tricuspid valve replacement, as we saw in the first case in this session, after the Starnes operation in multiple patients, and then after the Fontan operation, like we saw with the patient Marley that we're going to hear from her family shortly. And finally, we can also use the cone operation even in some cases after cone dehiscence or after like a redo cone. That's a common operation that Drs. De Silva can do after cones that were done somewhere else and that did not work perfectly. And also, they extrapolated that concept of the cone to other valves like the mitral valve or the patients with single ventricle, which can also be a successful repair in these patients.